Hello and a very warm welcome to the Good Information Live brought to you by The Journal. This event is part of the Good Information Project, which is an 18-month initiative that we've been running, taking a deep dive into 15 key topics that are impacting the lives of ourselves here and our place in the wider EU. We've been talking to reporters, experts, and most importantly to you, our audience, on what the information is that we need on these topics and trying to find that out and see if there are solutions. Our focus this month has been on healthcare and what it takes to build a better healthcare system with equitable and access for all. I'm Susan Daly, Managing Editor with Journal Media, and today we have the opportunity and privilege to go deep on a very important aspect of healthcare equity with our special guest, Peggy Maguire, who is Director of the European Institute of Women's Health. The Institute as an NGO was founded in 1996 with a specific focus initially to ensure women's and family health and well-being were kept on the agenda at European Parliament level and indeed at national parliament level, such as our own in Ireland. The team is proactive in promoting evidence-based understanding of the roles of sex and gender in order to increase understanding, managing and improving healthcare outcomes for everybody. The Institute has played an advisory role to many European level organisations, from the European Medicines Agency to the European Centre for Disease Control and Prevention, as well as to the World Health Organization on a number of matters. On that note, Peggy herself last year was appointed as a board member of the WHO Academy Quality Committee. Peggy's a political scientist who has worked with the European Union for the last 25 years, highlighting the need for gender equity in biomedical research, public health and social policy. She was a member of the expert group contributing to the WHO Women's Health Strategy for Europe. Peggy, that's a very long bio, but I think that's entirely appropriate for the work that you and the Institute have been doing. And I just want to know, did I get the description of the Institute's work right, or are there priorities that you're focusing on now that have moved on quite a bit since then?
No, I don't think you left anything out. I think just to go back the 25 years, I think the Institute started at the time when the Maastricht Treaty was just enforced in Europe, and it was the first time that Europe had a competency for health, mainly in prevention and health promotion. So it was a timely time actually, and it was as a result of a launch here of the Women's Health survey in Ireland, Attitudes and Behaviour, when 3,000 women here were interviewed about their health across the life course. So it was a very, very interesting topic. And at that launch, we had diverse stakeholder groupings, including members of the European Parliament, like Mary Benotti. And it became evident that there wasn't any specific focus on women's health at a policy level in Europe at that time. So after that then it was decided that what we really need was to set up a European Institute of Women's Health.
Going from 0 women there to interviewing 3,000, I imagine that's the first time that had happened in Ireland.
It was the first survey of its kind in Ireland, and Attitudes and Behaviour was done by Miriam Wiley in the SRI. So it was a very, very important piece of work to feed into policy for women's health in Ireland, for example. So we thought maybe we could do the same at a European level, not to the same extent, but that we would look at priorities that were needed. So we went to Luxembourg to meet the Commissioner for Health there, and there wasn't a Department of Health, they call them DGs, or Director Generals in Europe, and similar to departments here. So we met them, and really the Europe Against Cancer was really at full power at that stage in Europe, and we discussed the possibility of doing something on women's cancers, particularly information, because information was lacking on prevention and also access to treatment and care. So from that we then had a project on information for women, and we worked with the Irish Cancer Society on that project, and other countries as well, such as Holland. And in that project we worked with women, and the information that came out was for women and by women. We worked in women in the local community, women in the permanent TSB, I think women who were working, and also women who had had cancer. So therefore we had a very good cross-section. And the information was actually developed by the women themselves. So I think that was probably interesting at the time. And there wasn't any internet, but we actually put it on diskettes. At that time, I'll tell you how long ago it is.
Literally floppy disks.
Literally floppy disks, just so that we could distribute it widely. But we also worked with local authorities at regional level here in Ireland. We had a roadshow. And we worked with oncologists, oncology nurses, and the information that was devised by the women themselves was reviewed by oncologists and by oncology nurses, so that any information that was distributed by the oncologists and the nurses would also be information that women could access easily and easily understand, because that's a huge issue in relation to information.
So all of a sudden women are at both ends of that scale, contributing to the research, but also being able to access and see that research at the other end of it.
The terminology now is women as educators and women as part of the decision-making process. And I think that's so important. And that's sort of developed over the last 25 years, I think, now. And then the other issue was the fact that ageing was becoming an important issue in Europe at that time. The whole demographics was changing. And what we decided to do was to do a report on midlife and older women's health, and to highlight the issues that women of that age face, such as osteoporosis, depression, the whole area of the menopause, where there's a huge change for women, and also the lack of pension, the lack of pay, the whole pay disparity issues that were there at the time. And it's interesting, we've just actually finished revising that report last year in 2021, and it's amazing that the issues are still there.
So it's interesting, you start with healthcare, but then you found it cut across aspects of people's lives, everything from socioeconomic factors to education and so on. So when you thought you were starting out with healthcare, and you found gender gaps were all over the place.
Absolutely, yeah. Because I think, you know, at that time, I suppose we were, speaking to an audience that weren't really receptive at that time, and we're trying to convince people it wasn't just the biological aspects that were important, it was also the social determinants as well, like who you are, what your family is, like your genetic makeup, your education, your socioeconomic background, your ethnic origins, and your sexual identity were all important and all impact health. But it was really at that time, that discussion wasn't really starting at that point. It was a few years later that we had to work with different organisations, look at agencies at a European level. And it was around 2000 when we had a conference in Trinity on gender equity in public health that that's, I think, when it really started the information at a European level.
And that's 4 years after the Institute had started. Did you find that there was obviously at the time maybe a lack of reception, a lack of willingness to hear what was being said? Has that changed over time?
I think so, because we've worked with so many organisations. I'll give you the example of cardiovascular disease. I mean, that was one of the topics we were working on that long ago, and we worked with the European Heart Network. We did a report with them and the European Cardiology Society on the differences in men and women in relation to heart disease, and particularly the differences in women. I mean, it's underdiagnosed and under-recognised, even by women themselves. So we were discussing that at the time and trying to create more information and more awareness around cardiovascular disease and the impact that different, like, apart from biology, the impact of social determinants on heart disease on women across the life course.
Peggy, we mentioned the WHO's health strategy for Europe, and that obviously will cut across a lot of areas and conditions. Do you have a scorecard for how various European countries are performing? Are there some countries that are doing okay, or are there countries that need to be brought along?
Absolutely, I mean, you're absolutely right. I mean, there's huge disparities throughout Europe on women's health and access to proper health care. I mean, the WHO strategy looks at a life course approach, which the Institute always pushed from day one, that you have to look at a life course approach because there's so many different stages of a woman's life. And, you know, there are such disparities. Women, in Ireland, we're not doing too badly. You know, we have the Women's Health Action Plan now, and that really has, I think, moved into another dimension now for women in Ireland, where there was a radical listening exercise last year where women across the age groups were interviewed as to what they perceived positive and negative of the health system here. So on the basis of that, the action plan was discussed internally with the 30 members of the task force in the Department of Health across policy areas, and from that came the action plan. The department also had partners external to the department as well, such as the National Women's Council, the Institute of Public Health, Irish College of General Practitioners, and the National Women's Council of Ireland, who had initiated the process with the department, producing an evidence-based report on which the task force was actually built.
A lot of participation, collaboration and opportunity for women's voices to be heard.
I think an awful lot of voice, and I think when you're talking about changing, I think changing a health system, I think you are talking about a multi-level approach and a multi-expertise as well. I mean, you have to look at the clinicians, you have to look at the policymakers, the NGOs, and you have to involve everybody in creating this critical mass, because there is this understanding so change can be made. But you also need political will as well. If you haven't got the political will, nothing will ever change, and I think that's so important.
Why have we historically not had recognition of these issues? We're talking about it was in the 90s really where it started to pull focus on it. Is it because women just weren't at the table where those decisions were being made? And that's in a number of areas. You mentioned politics and also across medical research.
Yeah, I mean, I think, again, you're looking at multi-level. I mean, women weren't at the table from a policy-making perspective, political perspective. There were very few women in politics, and not so much even now. We're still trying to catch up. And also clinicians as well. I mean, they weren't, I mean, you've got to remember that, you know, sex and gender hasn't been included in the medical health profession and health professional curricula to date. And so therefore there was no full understanding of what women's health was all about, that it was different, that women are different to men. We are, you know, it's sort of, our makeup is different, and, you know, there's differences in disease processes. Diseases are different, some specific to women, some specific to men. And also the drug pathway and how women process drugs that they're given as well is different.
Can we actually talk about that, Peggy? I think that's very interesting. One of the areas of sex and gender missing representation is in clinical trials. Why is that important to resolve? And what is happening in Europe to do that at the moment?
I think this is the importance of Europe in the context of health as well, in that, you know, it is impacting at national level. So the clinical trials regulation was revised in 2014, but prior to that, women and older people were not included in clinical trials for drugs that they would have to take for different disease areas. So when the revision was coming up, the Institute looked at the legislation, the text of legislation, which we do. We always look at the current legislation and future legislation to see how we can influence. And we worked with other organisations to look at the text, amend it, and the wording, to amend the wording, we included gender and ageing, because as we said before, the biological differences, diseases are different in men and women. And also older people as well. They have comorbidities, they're taking more drugs, they're more likely to have adverse effects on, drugs are more likely to have adverse effects on them, as they are on women in general, because they're not included in clinical trials. So really what's happening is that drugs that are developed, they're tested on men, they were tested on men and not on women or older people. So thank goodness that in 2014, this amendment was tabled by supporters in the European Parliament, MEPs, and it was changed. So when the regulation came out, gender and age were included. So now, if women and older people aren't included in clinical trials, there has to be a very, very good reason why they're not. But prior to that, you know, there was no, when you're doing research, there was no criteria for funding that you had to include women or older people, even though the NIH in the States always had that as one of their criteria, that you must have a gender balance.
And it is now.
And it is, well, it is now.
Yeah.
And it comes into force now, the implementation at national level comes into force actually this year, okay, in January. So, you know, it's so important that that's implemented, yeah, and implemented in the right way, so that gender and age are included.
Interesting you mentioned pharmaceutical companies. So commercially funded, privately funded research, for obvious reasons, very, very important. A very large part of what we know and advances in healthcare, as we might have all gotten a little more used to understanding in the last few years. But as a result then, are pharmaceutical companies or other private research in this way, are they regulated in the same way? Do they have to include this kind of diversity, or is this where advocacy comes in and keeping the pressure up?
No, I think with the new clinical trials regulation now, the criteria is there now. So if they're doing research and they're applying to the European Medicines Agency for a drug authorisation, they have to concur, they have to involve women, and we just have to make sure and monitor it, that make sure that it actually does happen, you know. But yeah, moving forward, I mean, it's interesting at a European level where the Innovative Medicines Initiative, which is a public-private partnership between the European Commission and pharmaceutical industry, are working together on a lot of issues now at a European level. That Innovative Medicines Initiative has been changed as the Innovative Health Initiative. But more and more patient organisations, NGOs like ourselves, are becoming involved in those partnerships as well. For example, we have a project called Conception, which is looking at safety of medicines in pregnancy, for example. Like we lack a robust, comprehensive regulatory information system on access to safety of medicines in pregnancy. So therefore women haven't got the information, neither do their health professionals. And as part of this project, a survey was done of in 74 countries, and 85% of women said that they didn't have sufficient information on medicines in pregnancy, and the information they got, sometimes they couldn't understand it. It wasn't accessible information, and that they wanted more. So that's part of the Conception project, that they wanted to try and put together comprehensive information for health professionals and women, so that this doesn't occur. Because I think 5 million women give birth every year, and most of them have taken a medication. And sick women get pregnant, and pregnant women get sick. So therefore I think it's important that they have the information they need to make proper decisions. Because there's a lot of situations, I think, where women have chronic diseases, they might have diabetes, asthma, etc., and they have to take medications during pregnancy. And some of them will forgo breastfeeding following birth because they want to keep taking their medicines, or they stop taking their medicines. So women shouldn't have to make these choices without being informed of what's happening.
Absolutely, and I think we've done an investigation, this isn't really within the remit of your work, but we did an investigation in Noteworthy, the journal's investigative platform, around the use and the prescription of sodium valproate to women of childbearing age and women who became pregnant. In its own right, it's a very valuable drug, there's it's nothing wrong with it per se, but it should be used not within pregnancy, or there's a lot of difficulties around it, and there have been cases around this, not just in Ireland where people have talked about the side effects, but in Germany, France, Spain, it's fairly well documented. And the main issue there, as I said, was not that this wasn't an effective drug, it's just the thing it was treating, it shouldn't be used for pregnant women. That information was not being either passed on to GPs or to the women themselves, therefore they would never have taken it. And all of these women who later found out that side effects were as a result of this, they would never have taken it, because they would, if they'd had that information, they wouldn't have. And that was one of the things we found. It wasn't about, all the clinical research in the world was fine, it just fell down at the communication, and that was the horrible part for people. So I think with pregnant, the other thing is pregnancy. It is on one hand the most natural thing in the world, we're told. On the other side of things, why then is it not just the case that communication and information is absolutely the priority there for people?
Yeah, I think part of the problem is we don't have the data. We don't have the available data and information on the effects of drugs during pregnancy, because pregnant women aren't involved in clinical trials. And this all came about with thalidomide. That's right. Problem in I think it was the 60s. So the European Medicines Agency is even looking at this, and what they're looking at is investing and having a sustainable information system where there is data collected on the effects of different medicines in pregnancy, and also that the information is given properly to women and to their healthcare professionals. But the European Medicines Agency is in the process of having a strategy on the safe use of medicines during pregnancy, and this is so important. And we were part of a workshop in 2021 the agency organised on this topic, and we were talking about the woman's aspect and the pregnant woman's aspect to that. So on the basis, they were bringing all the information together. So what they want to do is collect the data and also have a robust post-marketing pharmacovigilance system as well. This is when the drug has been authorised, that it's being used, that any adverse effects or any bad effects are actually collected. All this information is collected. I mean, there are pregnancy registers in different disease topics, but they're too small, and the data isn't comprehensive enough to use. So that's why the Conception project is so important. I think there's 88 partners in it, and I think it's so important that we actually have this concrete and robust information that we can give to women, so that they don't have to worry, that they can make an informed choice.
And we were looking now, I suppose, at those specific areas, conditions and so on, and what's happening there. If, for example, your input there into the EU Beating Cancer strategy, what is missing for women there? And what are the recommendations around improving provision or targeting or awareness? I know there's been a report on women and lung cancer, which I suppose we may not necessarily associate with women if we're thinking lifestyle necessarily, but I mean, I would personally know people who have lung cancer or women, so, you know, it's obviously there. So could we talk a little bit about that?
Like lung cancer? Yeah, I think it's a very interesting topic because lung cancer is overtaking breast cancer in some countries, in the UK and Italy, for example.
Wow.
And this is a huge issue now for women, I think, because the incidence of lung cancer in men is lowering, but it's increasing in women, partly because of smoking. And particularly in Eastern Europe, for example, there's an increase in smoking and an increase of tobacco companies targeting young girls as well. So that's a huge issue. I think with the lung cancer, I think, you know, with the EU Beating Cancer plan, I think is really interesting because as part of that plan, they're going to have a review of the council recommendations on cancer screening, for example. Okay. So what they're hoping to do and potentially will do is include lung cancer as part of the screening process, as well as prostate cancer. So, I mean, I think that's an interesting development for women. But I think women are more susceptible to lung cancer, particularly because of smoking. Smoking has a very adverse effect on women. There are also, I think, environmental pollutants, etc., also have a bad effect on women. And there's also evidence to suggest that even if they don't smoke, they're more susceptible to lung cancer, non-smoking related. So I think, again, it's to go back to data again and data collection. We need more disaggregated data at a national level, and that's something that we have to look at in the future, and particularly the cancer registry. I mean, we have very good cancer registries in Europe, and look at that as well and see what they're doing in recording lung cancer incidence. But I think it's a very good question. I think women have to be aware of the issue of lung cancer, that it is increasing. And
I think a lot of those things are feeding into each other. So there's the initial data of, did you know that even if you're exposed to the same extent as a man, you are more likely to suffer the adverse effects?
Absolutely.
And then there's the next part is communicating that data once that's been gathered, and then it's having the targeting and the screening and so on. And when we talked about screening, obviously in Ireland, you know, we're coming out of a terrible time with cervical screening, with trust in it and trying to persuade women that, you know, you should be getting the screening done, you're getting that letter in the door. And it's how do we rebuild women's trust in things that we believe we probably did communicate are meant to be targeting and helping them. So the rebuilding of trust, is that really important?
That's hugely important, I think, and the whole communication is so important, and the building of health literacy among women as well. And disinformation, I think, is so pertinent, I think, even in relation to screening. I mean, screening is not a diagnostic tool, it's a preventative tool. It detects early cancer, so I think it's so important that women actually take this up. And particularly looking at cervical screening, for example, it's the one cancer. I mean, a lot of cancers are preventable, 40%, but I mean, cervical cancer, we can annihilate that through screening and HPV vaccination. And I think that's one area I think that is so important for women, and one that the Institute has always promoted over the years. I think we have to build trust in the policymakers. I think have to make sure that women are involved in planning the future. I think that's happened in a lot of countries now, where cervical screening is building up again post-COVID, and I think that really that's really impacted women as well in the whole screening process. So I think mistakes were made, I think, if you're talking about Ireland, but I think they have been rectified, and they're trying to build trust again in the whole screening programme. And I think women should definitely take it. I mean, it's one cancer that can be eradicated, but I think they should go for all cancer screening, breast cancer and bowel cancer as well. Yeah.
And when we were talking about cancers, we talked about cardiovascular disease as well. On other conditions that, I guess, if we're talking about research and data, I'd imagine is even more scarce or harder to gather together, something like mental health, which I know is an area you guys have been looking at, and the awareness of women suffering from depression. And, you know, we do have a lot of mental health initiatives in Ireland and beyond, but we do think about, say, suicide rates. We probably think of the male risk of that and so on, but women are very prone to depression, and then the older factor as well coming into it and linking in with menopause. Is that a huge area? How do you even tackle that?
Yeah, just before we could I just go back to the EU Beating Cancer
Yes, of course,
I think that's such a flagship really, and it's such an important plan I think for Europe, because the Commission are really looking at prevention, number one, and looking at health literacy and trying to inform the public again on the issue around prevention. So I think that's so important. And also I think they're looking at maybe vaccination and HPV, and maybe looking at that and how that can be improved across member states. But they've got a roadmap for it. They have progress indicators for the development of the work plan and the success of it. So they want to involve everybody at all levels, from research to prevention, diagnostics and treatment and care, to inequalities. And they've actually set up a stakeholder group in their European policy, a health policy platform, where some members of the Institute, Maeve Cusack, and I've mentioned the names, Hilary and Marlene, they're involved in those expert groups on the different aspects of cancer, so that we can get women's voice into what's needed, for example, in prevention. But they have a huge issue around health literacy as well, which I think is so important when it comes to healthcare for women, and to increase women's awareness and to involve women in health literacy and co-designing health promotion messages as well, I think is so important.
And that might be, the messaging might be different across communities, I'd imagine. When you talk about health literacy, for example, Peggy, what do you mean by that? Because in my mind there's probably a few different ways. It's sort of like where you're getting your information from. Language barriers can be an issue, or language isn't the issue in terms of, you're reading it in English, you understand English, but you don't understand the terminology because it's not phrased accessibly. Yeah. Is all of that part of it?
It's all of that as part of it. And also when you think of vulnerable groups and migrants, etc., which is now becoming a huge problem throughout Europe as well, and vulnerable groups, people living in poverty, people living in different parts of the country, how they access information through different channels. I think all of that has to be looked at, and to make sure that marginalised people are brought in and communicated with on health and prevention and well-being. They have to really, that has to be done in the future. Going back to the depression question, I think that's a life course issue. And what we're looking at the moment is looking from young people. I think one of the issues around young people, for example, is the whole issue of social media and how that's impacting on their mental health, from sort of body image to eating disorders and body dysmorphia. I think that's a huge issue. Yeah. And of course, as you mentioned, suicide. And that I think has to be addressed moving forward. Also, I think as to the suicide rate, I think that has to be looked at as well, particularly for older women, particularly entering the menopause. I think there's a whole stigma still attached to mental health and depression, for example. More women are likely to become depressed. And I think, again, communication with their health provider and their health professional is so important, that, sometimes a woman is more involved in looking after her family. She's the health manager, she's bringing her children to the doctor, she's looking after her partner, whereas she's not always looking after herself. And there's trigger points, I think, in a woman's life as well, where somebody can intervene and maybe give good healthcare messages, one of them being pregnancy, of course, where you can get good messages across on alcohol, smoking prevention, etc., and vaccination. And then menopause. One of the interesting things I think about women is that I think they feel they're not listened to, they're not taken seriously, and there is definitely a stigma attached to the whole area of mental health that we have to just do away with. I think everybody at some point in their life suffers some kind of mental health crisis, small, big. I think everybody does.
And if people do reach out, or they are starting to, because there is a lot more conversation happening around mental health that we may not have heard 10 years ago, 15 years ago. People, I suppose, even prolific or well-known people coming out and talking about their experiences. Government campaigns to say you can talk about this. But then on the short end of the stick is when they do come out. We mentioned eating disorders. We know in this country, for example, and it has been recognised even by the government this year, that eating disorder treatment is massively underfunded. There aren't enough places versus the scale of the problem, and that's for, there's a whole area of young men as well who are really suffering from eating disorders and disordered thinking about eating. and there isn't the resources there. So when we go back to that initial question, this is such a circular conversation around politics, about, you know, the policy makers and the willpower to put something in place. Ultimately, is that what needs to move in order for we can do all we can as a people and, you know, patient advocacy, but if the resources aren't there and the commitment to it, is that, I mean...
Couldn't agree with you more. I think, as we said before, you have to have the political will and the political leadership to want to do something about an issue. I think civil society has a role to play, because I think if you have a critical mass of ideas or opinions that something needs to be done, that can help as well. And also, of course, the whole area of health professionals as well. But I think, you know, a better way to look at it is like collaboratively work together and have an integrated approach and work with policymakers. Women work with policymakers, become part of the decision-making process and listen to women and what they want, because that's not done in any member state. I think Ireland is, to me, Ireland is one of the first people who've actually done that, who've actually listened to women and are making sort of decisions based on what women want. I think Scotland has got another, they have a similar health strategy. I think the UK is starting as well. So throughout Europe, there's different countries that are doing different things in relation to women's health. Germany's quite good on research and disaggregated data, but nobody has the full picture. And I think I would like to take the Irish model, to be honest with you. I'd like to take the Irish model and try and transfer it into the context of other European countries. Like we work with our focal point in Austria, the Institute of Public Health is one of our focal points, and they're very strong on mental health. So I'd like to talk to them, for example, and how they can utilise, say, the Women's Health Action Plan. But I know here, for example, that mental health is one of the priorities here, and we are looking at discussions with other organisations at a European level on a European mental health strategy. Because I think once it happens at a European level, it's inclined to filter down, and you have advocacy groups at a European level working on those issues. And including women in that aspect, that depression and mental health issues can be different for women and come at different points in their lives as well, and menopause being one of them.
Well, menopause, as you mentioned it there, and you know, you're saying Irish women are being listened to in a way, and I think, God, the European countries where they're not being listened to, I feel like if this is Irish people, women being listened to, it must be terrible state in other countries, because some Irish women might say, we actually don't feel that listened to sometimes, and particularly the conversation about the menopause that has been happening in the last 2 years. I think there was a very striking two-part Liveline episode where women came on and told their stories, and it was the first time a lot of people had heard or understood who hadn't gone through that experience. There's the access to things like HRT, there's being taken seriously by your health professional when you go and tell them, I'm suffering this symptom, and you know, it being diminished or dismissed. So are Irish women being listened to, or are we on the road there? What do you think about that whole movement about menopause? There's a big focus on it in the UK at the moment as well, but kind of led by personalities and civic organisations and so on, rather than from the other way around. It sounds like women are still shouting to be heard.
I mean, I think over the last 2 years, menopause has really come into its own.
Why is that, Peggy? Do we know?
I think it's a combination of factors, really. I think it's the evidence base is stronger now, that we know what's happening during the menopause. We know on the different issues that are occurring. And issues like cardiovascular disease have kind of spurred that on as well, because that's when cardiovascular diseases are more prevalent in women at that stage. But I think there's an MP in the UK who's been sort of at the forefront. I can't remember her name off the top of my head, but she's been at the forefront, where she's actually, I think, looking at a menopause policy, for example. And also there's policy now being looked at in menopause in workplace and employment, which I think is very interesting as well. So I mean, I think women are being listened to. It just takes that little bit extra time to get the political will and get the investment to deliver what's needed for women. And I think we have to keep talking about it. We have to keep sometimes shouting about it as well, and try to get our collaboration as well, and get our champions in, like our influencers in social media, and more particularly our politicians, because they're more important than anything else.
True. And we had the conversation, I mean, it's not anything we can solve here today, but there was a lot of conversation around the National Maternity Hospital, and when we were asking for questions, we were going to be talking to you, you know, people are concerned that women still have to fight to make sure that what's deemed clinically appropriate is clinically appropriate to being a woman, as opposed to the influence of any other organisation, say a religious organisation and so on. Was that understandable, that conversation in Ireland?
Absolutely, because I mean, I think it goes, again, back to our original question, I mean, women's health across the life course. And I think what women really want is certainty. They want certainty in the information they're getting is the correct information. They want certainty in that they're accessing appropriate treatment and care, and that good outcome. So it's certainty that women want, and that's building trust, I think, is such an important thing. But I think women's health is unique, and I think we have to take a life course approach to women's health, from early girls on teenagers right through to old age. And because women and men are different. So I mean, I think we need to take that. Health systems they've failed women in a lot of respects across Europe, and there's such disparities there. So I think that has to change, and there has to be a new movement towards equity in health and accessing it, and accessing proper healthcare throughout the life course.
I've kept you so long talking about our own questions. We have a few in from the audience around what they wanted to, just very specific questions that I think are quite interesting, and they're kind of linked. One of them was around the new announcement of menstrual leave in Spain that's actually linked to being state funded rather than companies, you know, paying for sick leave per se, that is actually ironed out here. Should more countries be doing this? Is this something that we can see happening in other countries? It seemed to come out of
the blue,
out of the left from Spain, but do you see that in conversations with Europe-wide, that there are interesting pockets of conversation happening?
I think it's great. I think it's great to have these conversations, because when you think of a young girl, young women entering this part of her life, she can't always talk about it. Who does she talk to? So I mean, that's the whole issue. I think it's great that it's normalising conversation around women's health, that there's not the stigma attached to menstrual cycle, for example. So I mean, I think it's good. Anything that we can talk about and normalise is fantastic, and I think that's a good thing. Yes.
Yeah. And Maria had a question about pain bias, which was something that I've read a little bit about, but I guess it was interesting to read. There's a bit of research coming on it, but how women have found that their reporting of pain has been dismissed or diminished, sometimes mentioned in the discussion about endometriosis. We're going back here to life phases in the course of life, and the symptoms being ignored as bad period pains. And there's so much like menopause that has also surged in people's awareness now as well. Is this down again to better education of health professionals? Is that the answer?
I think it's a combination of factors. I think you're looking at gender stereotypes, for example. I mean, there's a lot of unconscious bias out there to women. You know, that she's complaining, or it's a hypochondriac situation, etc. But there actually are gender differences in pain, and how people have pain, women and men. So there hasn't been, again, we don't have the data. We have to have more data and more research on what it is that, the evidence base there. But yes, I think it goes back again to the education of health professionals, and really there needs to be, in the curricular development, sex and gender have to be included, so that women's health are understood, that there are differences there. And yes, that's so important.
So there's biological differences, but then also tackling that unconscious bias. Look, it's a natural process. Absolutely. That every month you should be feeling pain.
Absolutely.
Or and how you scale that is sort of up to you, or even that thing about women being slightly anxious, or worrying too much, or hypochondria. Get that out of it.
Absolutely. And I think more discussion we have, the better, so that also women then can feel that that they can discuss these things as well, openly as well. I think it helps. It all helps.
Absolutely. And the general public. So when we're talking about involving people in research and starting off with those 3,000 women back in 1996 and getting their voices there, how can the general public get their voice heard in this? Are there a number of ways of getting involved? Is it just being more vocal in your treatment, or?
I mean, I think it's at different levels. And if you're talking about, for example, at a European level, I mean, I think, the next European elections are coming up in 2024. So I think women should ask their candidates, what are you doing for women's health? We have the EU Beating Cancer Plan, we have all these, there's so many strategies, there's so much legislation coming out that, I think maybe women should be made more aware of what's happening at a European level and ask their MEPs, future MEPs, what are they doing for them? You can have my vote, but what are you doing for me? I think this is so important. How they can get involved.
Yes, that's an obvious one.
You can always join the institute as well.
Yes.
That's not a problem.
Yeah.
And we have various ways that you can get involved in maybe if we're having focus groups on different topics, or we like to hear people's opinion as well on what they feel are important and what their priorities are.
That's great, and we'll put up a line in the playback of this video to give the website so you can go and have a look there and see what's happening as well. And what do you think is the next big thing that's going to be tackled, Peggy, in gender and sex representation in the world of healthcare? Is it one thing, or is it just to continue this progress? Is the pace happening? Is it changing quickly enough for your liking?
No, it'll never change quickly enough. But I think what we need to have, that women's health has to be considered, and sex and gender have to be included in the healthcare continuum, from research, the design of the research itself. Why are you doing this research? Who is it going to impact? To the results of the research that's disaggregated by age and sex, right through to health technology assessment when governments are actually deciding what drugs to buy and what technologies to buy. So, and education obviously for healthcare workers, and that's so important, and that it's updated as well as things change. But to have from research right through to clinical delivery of care is so that women's health or women's voices have to be included.
Absolutely. And just a final question from me about how you personally feel, hopeful or not hopeful, because you can do all of this great work, and within Europe there's a lot of collaboration. Then external to that, we've seen the conversation in America about the rollback of Roe versus Wade. We are concerned that there may be, things that have been a progression in women's health across Europe, including access to terminations if that's what's needed, that this might be rolled back, completely dependent on who's in power politically. Is that a thing that's in the back of the head of anybody working in this area? Or is it a real threat, or is this just a phase?
No, I think it's definitely in a lot of advocacy organisations. They realise that where they're getting their support from, because you're going to know who's supporting you at a parliamentary level. But I think it's important that women are made more aware of that. A change in politics can change in policy. So I think what's needed is, again, I think it's political leadership, it's investment and sustainable long-term investment in women's health, and then delivery. And until you have those three things, we can't improve women's health. But I think women should be more involved in the whole political process, and when elections are coming up, ask your candidate, what are you doing for women's health? And is this going to be sustainable? And what their issues are. So I would encourage all women to get involved if they can and want to in the whole democratic process, and because decisions are being made, and really we need the voice of women inputting into that decision-making process.
And seeking the good information on those topics through events like ours,
Absolutely.
or indeed through the Institute.
Absolutely.
Where I know we have it here. It almost looks like a prop, but it's the report card that you had for the last election in 2020.
Absolutely.
And you're hoping to update that to explain to people where we are in this whole area.
Absolutely. This is our manifesto from 2020, from 2018. Gosh, it doesn't seem that time is just flying by. But what we did in that was we gave the facts and figures of what was the issues around women's health and why they needed to be addressed. And then we looked at what Europe can do, and looking at the current legislation that's there, like for example the work-life balance and equal pay and pensions, clinical trials regulation, and these were the legislation. We'll be looking at further legislation at the European Beating Cancer Plan, the European Pharmaceutical Strategy, and Gender-Based Violence Roadmap, and Gender Equality Strategy. There's a huge amount of legislation that will have to be included in the next election. So we are looking for different new not new organisations, but new steps to be taken by politicians as well, like innovative steps that can influence better health for women, because that's what we're looking for. We want better outcomes for women. We want women are taught about prevention, are informed about prevention and keeping well. Not all about disease, etc., but more about wellness and how they can actually prevent disease throughout their lives.
Thanks so much, and thanks so much to Peggy Maguire joining us here today for that great in-depth look at gender and sex equity and access to healthcare. And thank you for tuning in. If you have any questions, you can send it to goodinformation@thejournal.ie and see more about the Good Information Project on our website at the moment. Thank you so much for that, Peggy, and exercise your vote and look for information, I think is key. Thanks.